Urinalysis, back to the basics. So here are our objectives. So pretty much today we're going to go over the very basics of some stuff you need to remember for your board exams and just to kind of pull back those memories of things from the basic urinalyses. So our objectives include labeling the main structures of the kidney, describing the function of the different parts of the kidney, understand the different chemical tests, their clinical significance, and the things that can cause false positives and negatives, and discuss the importance of confirmatory testing. These are all the things we're going to cover in this lecture. So we're going to start by looking at the urinary system. When we look at the urinary system, we've got the main one that everybody knows about, right? We've got the two kidneys, the two ureters, the bladder, and the urethra. So in the average normal person, this is what we're looking at. Now, we all heard the stories of a third kidney or only one kidney, things like that. But most people have this basic structure. But we really want to focus on the functional unit of the kidney, which is what we're functioning on when we're looking at the nephron. So the nephron starts up here at the glomerulus. You've got your afferent arteriole that goes into the glomerulus inside the Bowman's capsule. When it hits that, it's under super high pressure, and because of that, about 20% of the liquid portion of the plasma is going to get squeezed out into the glomerulus, and that is going to be our glomerular filtrate. So then if you look here at our efferent arteriole, and when you're looking at that, it's got about 20% less liquid volume. So if I could like put a little needle into that tiny little spot and do a hematocrit, it's going to be a much higher hematocrit because so much of the volume has come out into the glomerulus. But you'll notice we have this capillary bed that surrounds the functional unit, the entire nephron, and that is where a lot of the water is going to come back out of the kidney into the bloodstream. So it does come back. It does get reabsorbed pretty quickly. So, as I said, this glomerulus is under super high pressure. The glomerulus, think of it as a sieve. Think of it as a colander, right? So what happens is anything small can get through that colander. So when we're looking at this, we're looking at anything less than a molecular rate of about 60,000. So anything smaller than that can get through. So your ions, your glucoses, things like that can squeeze through. They're all going to be in that glomerular filtrate. Larger items such as your proteins, your albumins. Albumin is about 67,000 units. And because of that, proteins don't get through. So when you have that nice clean colander, that brand new colander you just brought home from the store, only the smallest things can get through. So think of your spaghetti. All that starch and all that little stuff, you're going to rinse it off. It's all going to get through your colander, but the spaghetti itself is not going to get through. It's too big to get through the holes. That's what you think of. When you're thinking of the glomerulus, think about a spaghetti strainer. The next part is going to be this proximal convoluted tubule. Proximal is the first, distal is the end, okay? One way to keep it straight. So in the proximal convoluted tubule, the primary function is to reabsorb. So what's happening is the body's like, haha, just kidding, I need that back. And it's going to start pulling all those things back that got through the glomerulus. Sugars, ions, all the sodium, potassium balances, all those things are going to get pulled back up by the body because the body needs those things. Think of the glucose. All that glucose can get through the kidney, get through the glomerulus. However, the body needs glucose for it to function. So the body reabsorbs all that glucose at that proximal convoluted tubule. So proximal convoluted tubule, primarily where reabsorption happens. Then we got our loop of Henle. Loop of Henle is where a lot of salt water balance is going to occur back into the bloodstream. And then you've got the distal convoluted tubule at the end. The distal convoluted tubule is primarily where the hydrogen ion exchange happens to maintain the pH of the bloodstream. Remember, the pH of the bloodstream is very narrow range, 735 to 745. Because of that, it's important. The kidneys are a very important part of maintaining that range. And the distal convoluted tubule is where most of that hydrogen ion exchange is going to take place. So final urine composition, 96% is going to be water. 2% inorganic or organic compounds, 2% inorganic compounds, and 1% miscellaneous. Hopefully you are all looking at this going, but Leah, wait, there's a problem. I have 101% there. That doesn't add up. The reason we do, this is what happens when you do too much rounding. This is why in our lab we're very particular about how many significant units to go out, because when you round, this is the kind of thing that happens. So bad rounding gives us to the 101%. But in general, we're looking at 96% water. The largest compound of urine composition is going to be water. The next largest component is going to be our urea. 55% of the 2% of organic compounds is going to be urea. So water and urea, those are the two. The rest of them are all pretty similar amounts. So the rest of them are all in kind of pretty much equal-ish amounts, but water and urea are the two that you do need to know. So in a routine urinalysis, there are 3 parts. We got our physical, where we look at the color, the clarity, the foam, the odor, and the concentration. Then you've got your chemical, where we're going to look at the pH, the protein, the blood, the nitrite, leukocyte esterase, glucose, ketones, bilirubin, and urobilinogen. And then the final will be the microscopic. What do you see? What is there? In this lecture, we are focusing on the chemical components of the urine testing. Of the routine urinalysis, we are going to focus on the chemical piece of it. Reagent strips, you've all seen these? They're out there, right? Everybody has seen what these look like. So what they are, they're little plastic strips, and each plastic strip has each little square on it, and each little square has a different chemical compound on it. When dipped with urine, the chemical reaction is going to take place, which is going to give us the different colors. When you're dipping a urine, you want to dip it in, drag it along the side, and you're going to want to blot the side of it. You need to remember that each of those pads has a little like divot between them. We don't want urine sitting in that, because that prolonged contact of urine with the pads is going to alter the chemical compound. So that's a very common question when you're going to see on a board or on an exam is prolonged exposure to urine. So that's why it's so important that we teach you how to blot it. Then at a specified time, we're going to compare the color of the pad to the color chart on the side of the bottle. This is old school with the paper. I like it because you can see the colors on it very easily for our situation for the video, but we all know it's on the sides of the bottles now. So interferences, you'll note one of my objectives talks about interferences. Why do we care? I got to teach in Tanzania for 3 months, and in Tanzania, things are a little bit different than here. The CLSI standards state that we must have an inert plastic container to transport the urine with a lid that must seal. Okay, we all know these lids, we haven't figured that out yet, right? But, okay, the lid must seal inert single-use plastic. However, in other countries, they do not use single-use plastic. They actually collected this urine. They put this number on it. They have a log, paper log, the number 29, that a patient's name next to it, and then all the test results go right on that log. So that's their only identification of this urine is this 29. When they're done, they take it and they dump it right into this big bucket of bleach water. And you can even see there's actually urine. You can see some of the yellow still in the vials. So in some countries, they still reuse glass and they wash it. So it's really important to make sure. Bleach in particular is a very common cause of false positives on the strips. So it's really important to recognize that. We don't use bleach much in the lab because it was so corrosive to our counters and our equipment, but some labs might still use bleach as a cleaning agent, so it's important to know. The other thing I want to point out are these strips here. On the bottom of these strips, the bottom pad is ascorbic acid. Ascorbic acid is a common interference we see, and that's vitamin C. So anybody that takes a lot of vitamin C, we're likely to have false negatives because it interferes. It's a reducing substance that's going to interfere with the color change and the chemical reactions on the strips. So in other countries, the strips actually do have an ascorbic acid spot, Europe in particular. When I was in Tanzania, all of our supplies came from Europe, so all the strips had that ascorbic acid pad on it. So let's start talking about the strips on the pads on the strips. The first one we're going to talk about, the first test we're going to look at is pH. pH is the degree of acidity or alkalinity of a urine. So normal blood pH, I said this before, but I'll say it again, 7.35 to 7.45, super narrow range. Our bodies do not like it when it goes on either side of that range. So our distal convoluted tubule is responsible for helping that hydrogen ions maintain that narrow range within the blood. The urine pH is anywhere from 4.5 to 8.0. That can be normal. So why do we care? Why do we test? If the normal range is so huge, what does it matter? I'll get you into this. On the bottom here, we've got a scale. It shows neutral is 7. Distilled water has a neutral acidity of 7. Neutral pH is 7. We got everything from very acidic, battery acid to stomach contents, down to very alkaline ammonia and bleach. I do have to point out, this is where I think people who drink the alkaline waters, you know, you're drinking that alkaline water and it's immediately going into a stomach with a pH of 2. Now the alkaline water, the pH is just a little over 7. It's just a little bit alkaline, and you're putting it into a pH of 2 stomach. Makes you kind of go, okay? Just wanted to throw it out there. So, pH, One of the reasons we test for pH is anything time you see a pH of greater than 8 in a urine, we kind of wonder about what type of integrity we're dealing with. What was the sample integrity? Because as urine sits at room temperature, the bacteria start multiplying and the pH starts going up. So anytime you have a pH of 8, the best course of action is to ask for a recollect, question the sample integrity. Abnormal pHs in urine can be due to diet. If you eat large amounts of fruits and vegetables, you're going to end up with an alkaline diet. If you eat large amounts of protein, you're going to end up with an acidic diet. And there's always the alkaline tide, where after a meal, all your hydrogen ions go running to your stomach to help you digest your meal. And because of that, there just aren't as many hydrogen ions to release into the urine, and then we end up getting this basic urine post meals. Certain drugs can cause alkaline or acidic urine. We sometimes treat people to make their urine a little more alkaline when we're trying to prevent kidney stones. If people are notorious for getting kidney stones, we're going to try to treat them to try to help that. And then sometimes we're going to treat for acidity if you're dealing with a urinary tract infection, so we're going to try to acidify the urine. Certain disease processes can cause regular abnormal urine pHs, meaning like more consistent. Respiratory disturbances, metabolic disturbances, that's going to mess with your acid-base balance, so that can affect your pH. And then also renal tubular acidosis. When you have renal tubular acidosis, there's a defect in your distal tubule, so its ability to maintain that hydrogen balance is going to be interfered with. So it's going to cause problems with the acid-base balance, which is going to affect your urine pH. There are no known interferences for pH. However, when you're dealing with the protein, sometimes if you leave the urine strip into the urine too long, you can actually get acid buffer run over from the protein pad, and it will cause a falsely low pH. So this is why it's really important to know how to dip and make sure that you're teaching others how to dip properly, because you don't want that extra protein buffer from going over. So another reason we actually test for pH though is to identify crystals. So yes, we're going to look at it for diet and short-term things and look for whether or not we have sample integrity issues, but we're also going to look for crystals. So when you're dealing with an acidic pH, we're dealing with acid pH crystals, your calcium oxalate, uric acid, amorphous urate, urine, leucine, tyrosine, and cysteine. Those are all crystals we're likely to see in acidic environment. When you're looking at your alkaline environment, your alkaline pH crystals, amorphous phosphate, triple phosphate, calcium carbonate, and ammonium biurate. So those are going to be the crystals we see when we're looking at alkaline pHs. So we find the pH to tell us when we're trying to decide what a crystal is. It gives us a direction to go, which path to head down. Second pad we're going to talk about is protein. Most strips are very specific for albumin. Albumin is a medium-sized protein with a 67,000 molecular weight. Remember I said a healthy glomerulus, anything less than 60,000 can come through. So albumin will be one of the first proteins we see that is going to be an early indicator of renal disease. So it's one of the first things we see when we start seeing that there was problems and damage to that glomerulus. Protein in a urine does not always signify disease. However, when you do see protein, it's going to automatically trigger additional testing. So we can look at 3 different forms of proteinuria: prerenal, renal, and postrenal proteinuria. Prerenal proteinuria is when we have a multiple myeloma patients and related plasma cell disorders. That can cause increased proteinuria. Hemolytic anemia. Whenever you have some sort of a hemolytic anemia of any sort, you're going to have damage to the glomerulus, and that's going to be your prerenal proteinuria. And then muscle degeneration, myoglobin, rhabdomyolysis, things like that can cause prerenal proteinuria. Renal proteinuria, glomerular proteinuria, like I said, when you get those larger damaged sieve, damaged glomerulus, so your sieve gets more damaged over time, your colander is brand new, your spaghetti's not going through, but as it gets older and older, some of the little colander holes get bigger and bigger, and all of a sudden you have spaghetti sneaking through. That's what we're looking at here. Tubular proteinuria, meaning there's an issue with the tubules within the nephron, and it's going to cause problems. Post renal proteinuria is after the kidney, and that's what we're going to see when we see a cystitis or a bladder infection. It's after the kidney. All of those could be reasons we see protein in the urine. Protein false negatives and positives. So false positives, any sort of highly buffered alkaline urine is going to override that buffering system, and it's going to cause a pH change that's unrelated to the actual protein. It's just going to show that there was a pH issue. When you allow the reagent pad to be in contact with the urine for too long, it can remove that buffer. So we don't want to like leave it and just soak it in that urine. Highly pigmented specimens, any of our urine pads that start out as a light color, those buff colors and off-white colors, anytime you have a highly pigmented urine, it's going to change the color of the pad, and that's going to be unrelated to protein. It's just staining the pad. And then contamination of the urine container with certain cleaning agents, bleach, oxidizing agents, things like that. Anytime you see bleach or cleaning agents, that is oftentimes going to cause false positives. So if you have a question on your boards about what causes a false positive and you can't remember, but bleach is one of your answers, it's going to be a good guess. On the other side, for false negatives, high salt concentrations are going to lower the sensitivity of the test. The strip sensitivity, its method is very sensitive to albumin only, so it's not likely to pick up Bence-Jones proteins and immunoglobulins and such, because it's only going to detect the albumin. And if you have very dilute urine, you're not as likely to pick up the protein in it. So a concentrated urine is a better specimen. Now, protein confirmation, I don't know of any labs that actually do this test anymore, but it's important to know it's going to likely show up on your boards, case studies as discrepancies, things like that. The sulfosalicylic acid precipitation test, the SSA test. What we do is we take urine and we mix it with an acid and we invert it a few times, and the protein will actually precipitate out. Then we compare the degree of turbidity. We look at some lines through it, and the higher the turbidity, the higher the amount of protein in it. Some false positives include turbidity of the urine before you start. So if you have a turbid urine to start, you definitely want to spin it down before you do this. And other substances that can get precipitated out by acid, primarily this radio contrast media, that kind of stuff is really, really rough, and it causes a lot of interferences in the lab. False negatives, a very highly buffered urine and a very dilute urine. So, again, the highly buffered urine is going to cause a false negative SSA, but it's going to cause a false positive strip. So it's kind of important to pay attention to those as we do them. This next pad we're going to talk about is blood. There's three different categories that we talk about: hematuria, hemoglobinuria, and myoglobinuria. So the presence of intact red cells is hematuria. This is when we see this when we see trauma or damage. It's bleeding within the urinary tract infection. Tumors, stones, things like that can all cause it. Hemoglobinuria is the presence of lyse cells. This is when we're looking at intravascular hemolysis, and the hemoglobin is getting filtered through the glomerulus. We see this with transfusion reactions, hemolytic anemia, severe burns, infections, and even brown recluse spider bites we can sometimes see this in. The other time we can sometimes see this is in dilute or alkaline urine. What might have been intact red cells in a dilute or alkaline urine is going to appear as hemoglobinuria. True hemoglobinuria is when you're dealing with intravascular hemolysis and not the whole cells. So dilute or alkaline urine might make it look like hemoglobinuria when it was actually hematuria. The last one is myoglobinuria, and that is the presence of myoglobin. Myoglobin is a heme-containing protein that's in muscle tissue. And what happens is you have a disease called rhabdomyolysis. So something happens, and oftentimes it's a crush injury. It can be trauma, prolonged coma, and extreme exercise can even cause it. There used to be a bunch of case studies. There's a bunch of case studies out there with regards to CrossFit causing rhabdomyolysis. It's really some fascinating reads about extreme exercise. If it's something that interests you, definitely look into it. And in this situation, what happens is it causes this muscle breakdown when you have all these injuries, and it releases myoglobin and ends up causing severe kidney disease. So when we're looking for false positives and negatives, false positives, strong oxidizing agents, bleach. Again, anytime you see a false positive, cleaning agents, bleach, strong oxidizers, oftentimes are going to be your false positives. Bacterial peroxidase can cause a false positive. And then menstrual contamination. Now, I don't like that this is in here as a false positive. I don't like that it's in the books. It's still called a false positive. It's not a true false positive. There is blood. Menstrual contamination is blood. However, it's contamination. It's important to look at, though, when you see blood in a woman of childbearing age, to always consider, is this menstrual contamination or is it a true blood due to a bleed? Now, our false negatives, high specific gravity is going to crenate the cells, and when the cells are crenated, when they hit the pad, they're not going to burst. So in order for the pad to work, the cells have to hit the pad and burst. And think of a water balloon. If you have a water balloon and you fill it all the way nice and full, when it hits the pad, when it hits anything, we can throw it around and they're going to be busting all over the place. If I only put a little bit of water in a water balloon, we're going to be able to throw that water balloon all over the place and it's never going to burst. So that's what we're looking at when we're looking at this, is we want to make sure that these cells, if they're crenated and they hit the pad, we're not likely to have them bust, and you're going to have some false negatives. Ascorbic acid. Ascorbic acid is the leading cause of false negatives on all the strips. It's a reducing substance. So if, again, you can't remember and it's a false negative question and ascorbic acid is one of the answers and you can't remember the answer, it's a really good guess picking that ascorbic acid. And then unmixed specimens. If I dip a urine and it's been sitting there for a while, all those red cells are going to settle to the bottom and I'm likely to get a false negative. So it's always important to make sure before you open a urine to test, you give it a nice swirl before you test it. For blood, our confirmatory test is going to be a microscopic. If it's a true hematuria and it's hemolyzed red cells, you are not going to see any positivity of red cells on the microscopic. But a microscopic is our confirmatory test for blood. Leukocyte esterase is the next pad we're going to talk about. It's an enzyme. Leukocyte esterase is an enzyme present in the granules of neutrophils, basophils, and eosinophils. It is not present in your lymphocytes or monocytes. Oftentimes, we'll see a positive leukocyte esterase with present in vaginal contamination. And most often, though, when we see a positive leukocyte esterase, it's in the presence of bacterial infection and contamination. So this is one of those ones where you're going to want to look at the pH. If the pH is 8 or greater, chances are really good it's contamination and it's had time to sit and grow for a while. Leukocyte esterase, false positives. There's our strong oxidizing agents again. Pay attention to that one. Highly pigmented urine. Again, this is one of those light color off-white pads. So anything that's highly pigmented is going to change the color of the pad. And then what's interesting is nitrofurantoin. Nitrofurantoin is an antibiotic that we give to people for urinary tract infections, but it's going to cause a false positive on the leukocyte esterase. So it's not going to be a good indicator of what's going on once they start getting the nitrofurantoin. False negatives. High concentrations of glucose and protein are going to block the pad. Because again, these pads, the cells have to hit the pad and the granules have to hit the pad in order for the reaction to take place. Ascorbic acid, there it is again, false negative, it's going to cause a problem. And then inaccurate timing. The white cells take 2 full minutes in order to read the pad. If you read it too early, it may not change and you're going to get a false negative. Conversely, if you let it sit for too long, after about 5 minutes, just exposed to air, the pad's going to oxidize and it's going to turn positive. So if you have the pad sitting there and a couple, 5, 6, 7 minutes later, you look over and, oh, it's positive, don't change the answer, because it's really important to have the right timing for this pad to know that the answer truly is positive or negative. So our confirmatory test for leukocyte esterase is also going to be a microscopic. Nitrites. Nitrite is a screening for the test for the presence of UTIs. So what nitrates are, when you're looking at nitrites, is you are looking at the nitrate in the body, the bacteria utilize the nitrate, produce the nitrite. So it's just a screen for the presence. Some of the false positives we see with nitrites, however, is when you're dealing with an old properly stored specimen, contaminant bacteria can multiply. About every 20 minutes, E. coli doubles. So if you have a handful of contaminant bacteria, a handful of E. coli floating around in the urine and it's sitting there, it's going to double every 20 minutes. So that urine gets to be 2, 3, 4 hours old, and there's going to be a lot of bacteria in it. Again, it's a light color pad, so any highly pigmented pad or urine is going to change the color of the pad. False negatives. Now this is where things get interested with these, because remember, this is a screening test for bacteria in particular that can change your nitrates to nitrites. Not all bacteria can reduce nitrate to nitrite, especially your enterococcuses and your gram-positive cocci can't do it. So the screening test will be negative, but bacteria could still be present. Bacteria require 4 hours in the bladder to reduce the nitrates to nitrites. So it takes 4 hours for some of this to happen. So it's important to make sure you get that concentrated specimen. This is why first morning specimens are the best specimen when we're looking for bacteria. Inadequate consumption of green vegetables. If you live on a diet of ramen, mac and cheese, and pizza, you may not have enough green vegetables to have nitrate in your body to convert to the nitrite. Some bacteria are really good at taking that nitrite all the way to nitrogen gas. So you can have a false negative because the bacteria take the nitrate to the nitrite all the way to the nitrogen gas, in which case it misses that intermediary in nitrites. Excess amounts of ascorbic acid, there it is again. I'm telling you, if you remember 2 things from this lecture, remember false positives, bleach and oxidizing, false negatives, ascorbic acid. High specific gravity and low pH are also something that's going to cause false negatives. However, urinary tract infections tend to have a high pH in general. The bacterial production creates the higher pH, so you're not likely to see this in a true urinary tract infection. Glucose. So in glucose, we have to have glucose. Our body requires it. It's the primary source of energy in our body for cells. It easily gets through this glomerulus and is reabsorbed in that proximal convoluted tubule. Remember, the proximal convoluted tubule is where most of the reabsorption of everything that gets through comes back into the body. The renal threshold of glucose is 160 to 180 milligrams per deciliter. What that means is your body can handle and reabsorb a normal plasma glucose of around 160 to 180. We start getting higher than that, we'll see what happens. So here is the normal, what's going on in the kidney. Arterial plasma glucose is running about 100 milligrams per deciliter. It filters out about 130 milligrams per minute, but the proximal convoluted tubule is really good at reabsorbing that, and it can reabsorb that full 130 milligrams per minute. So we have no glucose formation in the urine. So this is normal, healthy, able to handle the sugars. Now, when we're looking at prerenal glucosuria, hyperglycemia, we're looking at diabetes, pancreatitis, or hyperthyroidism can all cause this. And what's happening in this situation is our arterial plasma glucose is running about 300 milligrams per deciliter. The glomerulus is able to filter out 390 milligrams per minute. However, the glucose reabsorbed can't handle that. It can only handle about 350 milligrams per minute of reabsorbing, which means we end up with about 40 milligrams per minute in the base of urine glucose, of what's happening in the bottom. I think of this as the I Love Lucy, the candy factory, where it's coming in and they're wrapping the candies, and all of a sudden it's coming in so fast, all that candy's going out the end. That's kind of what's going on here. The body can only wrap the candy or reabsorb the sugar as fast as it can, and whatever it can't get to is going out the end. Now, renal glucosuria, we see this when we're dealing with tubular reabsorption disorders such as Fanconi's syndrome. So in renal glucosuria, we have an arterial plasma glucose of 100 milligrams per deciliter. That's normal. That's a normal person's plasma glucose. Our body can filter out 130 milligrams per minute, if you remember from that first slide, in normal. However, in this situation, the proximal convoluted tubule has some sort of a disease. Something's going on, and the body is unable to reabsorb the sugar and the glucose at that level. So it only reabsorbs at the level of 70 milligrams per minute. And because that, we're losing 60 milligrams per minute of sugar into the urine. So the proximal convoluted tubules just cannot reabsorb the sugar to the amount that it can when it's healthy. So we're looking at glucose false positives and negatives. Oxidizing agents and detergents, again, is our false positive. False negative, there's that ascorbic acid again. Remember those two. Other false negatives, high levels of ketones, high specific gravity, or an improperly preserved specimen. Because over time, as the bacteria go up, it eats the glucose, and the glucose levels will go down for those older specimens. Next pad we're going to talk about are the ketones. There are 3 intermediate products in fat metabolism. You got your beta-hydroxybutyric acid, your acetoacetic acid, and your acetone. If one is there, they are all there. So most strips only test for 1 or 2. Does not have to test for all 3, because if any one is there, they go back and forth and they're all there. The clinical significance of ketones, Diabetic ketoacidosis, starvation, strenuous exercise, long-term vomiting. The other time we see this, and it's not really a clinical significant, it just happens, is the keto diet. Every January, everybody, takes these New Year's resolutions. They all go on the keto diet for a month. We see a lot of ketones, and then they start dropping down. Throughout the year, you see these little spikes in your patients that come through with the ketones in their urine due to the keto diet. False positives and negatives. Your false positives, your phthalate dyes, any sort of highly pigmented urine. Again, it's going to stain that light colored pad. And the other one that's really interesting is false positives is your levodopa. It's a Parkinson's med. And there are certain other drugs, but we see this one quite a bit. It's a pretty common Parkinson's med. So the levodopa is going to cause false positives. False negatives include improperly specimen handling. Over time, the acetone volatilizes pretty rapidly. Bacteria is going to break it down and allow it to volatilize even more rapidly. So improper handling is going to be our most common cause of false negatives. Now, bilirubin and urobilinogen. Bilirubin, so this is the normal, what happens in a normal person. Red cells, they get lysed, they turn to hemoglobin, convert to porphyrin, convert to the unconjugated bilirubin. It goes into the liver, becomes conjugated, spills out into the intestine. The bacteria are going to take that conjugated bilirubin, convert it to urobilinogen, which converts to urobilin, and that gives us the color of our feces, is the urobilin. Now, urobilinogen, about 10%, leaves the intestines, gets recirculated in the bloodstream, and goes back to the liver and back to the kidney. This is why urobilinogen should never be zero. Our strips report out as low as 0.2 milligrams per deciliter. You can never report out a negative urobilinogen because you cannot report out anything less than 0.2 because it's normal there. Some strips just call it normal. Some strips have a number for it. So in a normal, healthy person, there's always a little bit of urobilinogen, and there is no bilirubin. The bilirubin is negative. Now, these three cases, increased red cell destruction, liver disease, and a blocked bile duct. These three cases are important for you to understand what's going on in the kidneys, in the urine. So, increased red cell destruction up here at the top. We have red cell lysis. There's extra red cell lysis, meaning in the bloodstream we have excess hemoglobin, excess porphyrin, excess unconjugated bilirubin, goes into the liver, it conjugates. Now, in this situation, we are working with a healthy liver. The liver is able to take all that red cell destruction, all that unconjugated bilirubin, and conjugate it all. So it goes to bile duct, into the intestines, makes urobilinogen, urobilin into the feces. So the liver takes care of it all. Where we see something with increased red cell destruction, there is more urobilinogen being produced in the intestines. So therefore, about 10% is a higher amount. So that higher amount of urobilinogen gets recirculated to the liver and to the kidney, where the bilirubin is still negative, but the urobilinogen is elevated. So in increased red cell destruction, we expect to see a negative bilirubin and an elevated urobilinogen. Now, second case is liver disease. The red cell lysis is normal, hemoglobin, porphyrin, the unconjugated bilirubin. However, when we get that unconjugated bilirubin into the liver is unable to conjugate it. It's not working, it's not functioning as well, it's not doing as well. So in this situation, the bacteria turns to urobilinogen. The little bit that does get through, the bacteria turns that bilirubin into urobilinogen, into urobilin, but when it recirculates, we have an issue where the urobilinogen does not recirculate back to the liver because the liver's not working well, so all that extra urobilinogen is circulating to the kidney. The other thing is because the liver's not working well, it's not able to conjugate all that bilirubin, and it's not all going into the intestines, it's leaking. It's a leaky liver. So because of that, we have this extra line where the leaked bilirubin gets into the bloodstream, and the kidneys are responsible for getting rid of it. So in the liver disease, we expect to see an elevated bilirubin and an elevated urobilinogen both. The final case is when we're looking at the blocked bile duct. We're looking at the blocked bile duct. Everything up here on top is normal lysis, normal breaking down through. The liver is working. It's breaking down the bilirubin from unconjugated. It's conjugating the bilirubin, but it can't get through. We got this blocked bile duct, this stone here. So because the bilirubin can't leak through, it's all leaking out of the liver into the bloodstream. Because it's not going into the intestines, it's not converting to the urobilinogen. It's not converting to urobilin because there's no bilirubin or very little bilirubin getting into the intestines. So in this situation, our feces become very, very pale. There is no urobilinogen recirculating, so there's none for the kidney. And because it's blocked, all that extra conjugated bilirubin is getting blocked up and it's going to spill into the bloodstream. So when we're dealing with a blocked bile duct, we have a much lower urobilinogen, so it'll be less than normal, and a positive bilirubin. False positives and negatives. False positives, primarily you're looking at a highly pigmented urine, things like pyridine. Again, it's one of those off-white pads. Anything that's pigmented is going to stain the pad. And then the false negative, exposure to light. Is going to break it down. This is why, you know, when we collect baby billies, we collect them in the little amber tubes, things like that. It'll also affect our urines. And then there's our ascorbic acid, our false negatives caused by ascorbic acid also. For bilirubin, we do have a confirmatory test, an icto test or an icto check. For a while, we weren't able to get the material to make icto tests. They became unavailable for quite a while. This other company came out with this icto check. Icto test is less susceptible to interferences and is more sensitive. The normal sensitivity of a strip is about 0.4 milligrams per deciliter. The sensitivity of the icto test is 0.05 milligrams per deciliter, so quite a bit more sensitive. So if you think there might be some bilirubin, the bilirubin pad is positive, but you really don't know if it's a color issue or something else is causing the problem, we can do the icto test and determine if it is bilirubin is truly there or not. The last thing I want to talk about is the Clinitest. Now, the Clinitest is not a confirmatory test. A lot of students get confused. They consider it a confirmatory test for glucose. It is not. Sensitivity of glucose on a strip is 75%. It's very specific for glucose. Sensitivity for Clinitest is 250 milligrams per deciliter, and it's not specific at all. It's any reducing substances. I do want to say also, Clinitest is also known as the copper reduction test. It's kind of like when we call all those things we blow our noses on. We know it's facial tissue, but we call them all a Kleenex. Clinitest is it's the same way. It's the brand name for a copper reduction test. The principle of the procedure is copper reduction. It's based on the ability of glucose and other reducing substances to reduce the copper sulfate to cuprous in the presence of a reducing substance. So when we're looking at this, primarily we look at this for kids under the age of 2 is who we used to do this for. And what you would see, and it's a common case study where you're going to see this, it might be a board question. The glucose is negative on the strip, but the Clinitest is positive. And if you look, it's a young child and they have galactosemia, for example, because galactose is one of those sugars that does not get picked up on the strip, but does get picked up with Clinitest. So it's a really great board question as a contradiction. Why, what is wrong with this? Where are your contradictions? What's happening? Clinitest is positive, but the glucose strip is negative. It's looking for other reducing substances. That's the end of the lecture. If you have any questions, please feel free to reach out. My email is there, and you have already found the YouTube channel, so hopefully I'm able to help you with some of your review for boards.